let's move on to the last session. We've talked a lot about different genotypes wedded to targeted therapies, this whole concept of precision medicine. Not all non-small cell lung cancer is one disease. We've learned it can be parsed out now into more and more genotypes. I mean, we've learned even from the LCMC data, patients with a genotype who get a targeted therapy live longer than patients with a genotype who don't. So I think that there's just a wealth of information and a groundswell of drugs that we've really moved into this era of really understanding the genomic characterization of a tumor, lung cancer, that informs us on targeted therapies. And obviously not every patient is going to get a targeted therapy, but there's a growing list of these mutations. So it really, I think it's nice that we end up on this, how do we collect this information? What is best practices for molecular testing? And I don't think we should go center by center, but Zofia, maybe you can start us off and just give me your impression of how this should best be done. We have too good a data now, for it not to be done.
It's true. I think, what's really important from all of these different mutations and rearrangements that we're seeing is that we really need to be sure that we're casting a broad enough net with our testing to capture these different rearrangements and alterations. So ultimately, I think that next generation sequencing is really, with a broad panel that covers all of these different genes of interest, is really essential and important. I think, on a practical level, sometimes NGS testing can take some time to do. Even at Mass General, our NGS panel can take a couple of weeks to return. That can be sometimes difficult. The PD-L1 testing comes back early. Patients are anxious to start treatment. Physicians are anxious to start treatment. But I do think it's important to wait for that data if at all possible. In order to kind of facilitate that, when we have patients at our center who are never smokers, who have some of these features that make these mutations more likely, more probable, we do have some more rapid testing that can be done to look for the kind of lowest hanging fruit. So for example, we have a rapid EGFR PCR-based assay that comes back in just a few days. We have ALK and ROS1 IHC, so that you capture those kind of largest pieces of the pie early. But ultimately, I think NGS testing is really going to be the gold standard and is going to help us capture these mutations. It can easily be modified to add future genes of interest as well. So
yeah, it sounds great in practice, and we try comprehensive genomic profiling, maybe a focus on specific genotypes that are low-hanging fruit with a more rapid turnaround time. What are some of the hurdles with this, though? What are the hurdles that are out there in the community or even in academia in terms of getting tissue testing done? Jonathan?
I think Zofia alluded to some of them. At UC Davis, we do PD-L1 in-house, but we do send out typically for a next generation sequencing platform, for broad genomic profiling. And, that can take some time to come back. It could take some time for the pathologist to send out the tissue. Ideally, the guidelines talk about having results within 2 weeks. But the turnaround for the NGS panel, as well as time for it to receive the tissue, insurance authorization, so forth, can sometimes be rate limiting. So, for patients who are asymptomatic or minimally symptomatic, who can wait, my general approach has been a broad next generation sequencing profile on tissue. For patients that cannot wait, that are never smokers, and I think have a high probability of having EGFR, ALK, ROS1, I will often send for EGFR, PCR, ALK, IHC, or FISH and ROS1 FISH to try to get those results. And I found, particularly the FISH and IHC tests, you can get much faster. For example, I had an ALK patient who was in the ICU with pericardial tamponade, who I saw, and ALK patients they seem to be associated more with having effusions, pericardium, pleural. So we had an inkling that she could have an ALK, so we sent that off. We harassed pathology to send the tissue out, and we had a result in less than 48 hours, and we were able to get them on alectinib, and did great. So those are the situations where I'll deviate from the broad genomic profiling. Another thing sometimes is you wind up in situations where there's a bone biopsy and you can't get a good NGS panel due to the decalcification process. And in those situations, I'll try to get plasma initially to try, and sometimes can find decisions based on that. Of course, a negative plasma test doesn't necessarily rule out that they won't have anything. But if it's positive for something, that can really help you as well. So those are some special situations where I may not always step to the broad genomic profiling first and to try to accelerate things.
Yeah, I think another important point is we've talked a lot about who we think about screening with NGS, and we've mentioned the never smoking younger patients. But one striking thing about one of the newer drivers that we've learned about is that there are these MET exon 14 alterations, almost a comparable frequency to ALK rearrangements. But these tend to occur in older patients, a median age of greater than 70, and there's a higher proportion of smokers. So I think that we should actually, and many of us are moving towards a paradigm where we're not being biased in terms of clinical features, but broadly
Everybody.
testing lung cancers. And just to sum up the importance of that, crizotinib can work well for these MET exon 14 alterations. It's in the NCCN guidelines. And there are now newer drugs like tepotinib where we're seeing response rates greater than 60%.